نتكلم عن role of imaging in thyroid disease management.
Good morning. Thank you very much for having me today, and special thanks to Dr. Tamer El-Sharbini for this kind invitation for this conference. As you know, today I will be talking about thyroid imaging techniques in practice. We will take thyroid nodule assessment, ultrasonography, and some ancillary imaging techniques like elastography, computed tomography, scintigraphy, and PET scan. As we know, the high-resolution high-resolution ultrasonography is the most sensitive test available for detecting thyroid nodules and diseases. The ultrasound report should include nodule size in 3 dimensions and the location of the nodule within the thyroid loops. A detailed description of the nodule sonographic features, including composition, echogenicity, margins, presence, and types of calcifications, and also the shape of the nodule if it is taller than wide, and the vascularity. We are using the linear array transducer, and we are using frequencies 7.5 megahertz and above to better visualize the thyroid. We should put a rule under the patient's shoulders to raise it above the clavicles, and then we move the transducer above the trachea, just above the trachea, and move it through the thyroid loops to survey the loops as we see here. We will see the right lobe as shown here, and the left lobe here, and this is the isthmus, and this is the longitudinal aspect of the thyroid lobe. The normal thyroid anatomy should be familiar to us. As we see here, this is the right lobe, the left lobe, and the isthmus, and just posterior to the isthmus we see the trachea, and also just posterior to the left lobe we see the esophagus, and laterally we see the common carotid artery, the internal jugular vein, and also we should know that this is the longus colli muscle, and the more important, we know that there are the strap muscles, sternocleidomastoid, sternohyoid muscle, and sternothyroid muscle. We should focus when we are doing ultrasonography about echogenicity, if it is isoechoic, hypo, hyper, and markedly hypoechoic, and also the echo texture, if it is fine, coarse, and micronodulative. The vascularity also is important. We should know if it is normal, decreased, mildly increased, or markedly increased, and also the margins, if they are smooth, microlobulated, or macrolobulated. About echogenicity, this is isoechoic thyroid, and this is hyperechoic thyroid, and this is hypoechoic, and this is markedly hypoechoic. How we classified them? We just look to the strap muscles and compare the echogenicity of the thyroid lobes. If it is slightly brighter than the strap muscles, it is isoechoic. Markedly hyper than the strap muscles, it is hyperechoic. Just similar to the strap muscles, it is hypoechoic, and if they are darker than the strap muscles, this is markedly hypoechoic. We see the hypoechoic and markedly hypoechoic in the autoimmune thyroiditis. Echo texture, as we see here, this is fine, this is micronodular, this is micronodules, and also this is the micronodules, and this is a coarse. We are seeing here septa, fibrous septa. All these micronodular and coarse are seen in the autoimmune thyroiditis. Vascularity, we may see decreased vascularity, small areas that take vascularity, and this is pattern O or pattern 0. If it is there are scattered vascularity, this is pattern 1 or normal, and they are seen in the normal thyroid gland. In the autoimmune thyroiditis, we see that markedly increased pattern 2, or diffusely increased pattern 3, or what is titled thyroid inferno, which is seen with Graves' disease. The thyroid margins, as we see here, it is smooth. This is microlobulated and lobulated margins. So the normal thyroid appearance is isoechoic, smooth margins, fine ecotexture, normal vascularity, Doppler pattern 0 or 1, and there are no microcalcifications. The loop within the transverse aspect will be triangular in shape, and the diameter is about 1 to 2 centimeters, while it is oval in the longitudinal aspect, as we see. This is an example for normal thyroid gland. Hashimoto thyroiditis, the classic pattern of it is enlarged thyroid gland and diffusely heterogeneous and coarse ecotexture. Also, we see hypoechoic micronodules ranging from 1 to 6 millimeters in diameter, the coarse septations from fibrous bands, and also microlobulated margins, as we see here. The color Doppler, flow Doppler may demonstrate slightly to markedly increased vascularity. This is an example for Hashimoto thyroiditis, and as we see here, this is the micronodules. And this is the fibrous septa here. Backing to our survey and your responses, which sonographic sign is highly characteristic of Hashimoto thyroiditis? Most of you answered that heterogeneity is the most characteristic sign. But we see here that the micronodules has a positive predictive value of more than 90%. 90%. These micronodules have been reported to range from 1 to 7 millimeters in size, as we mentioned, and as we show here. About Graves' disease, the ultrasonographic classic pattern is also enlarged gland, also heterogeneous or coarse ecotexture, diffusely hypoechoic structure with short fibrous septa. But the important thing here that the Doppler demonstrate pattern 3 vascularity, or what titled thyroid inferno. The inferior thyroid artery systolic velocity is more than 65 centimeters, and in most cases it is more than 150 centimeters per second. This is an example for thyroid inferno, but some cases of thyroid Graves' disease show just pattern 2 of vascularity. Also, backing to your survey, can ultrasonography thyroid differentiate between Graves' disease and Hashimoto thyroiditis? And also, most of you answered that no, that yes, it can, but the sonography has high specificity but low sensitivity in the diagnosis of either Graves' disease or Hashimoto thyroiditis. It is therefore not possible to differentiate between these two diseases using sonography alone. Confirmation by laboratory data is also needed, but in practice we are not facing such scenarios unless the patient came to us just with a sonography image. Of course, we will wait for the laboratory. The subacute thyroiditis is also another important entity. It may be unilateral, but in most of cases it is. In most of cases it be unilateral. Some cases bilateral. The thyroid gland is typically enlarged, painful. The most characteristic sign is focally ill-defined, heterogeneously hypoechoic areas within a regular or microlobulated margin, as shown here. This is an irregular borders, hypoechoic area, and also the no hypervascularity within the area, the affected area. This is an example of it. This is a bilateral subacute thyroiditis, unilateral subacute thyroiditis here. Sometimes it is difficult to differentiate it from thyroid carcinoma unless we do fine needle aspiration. Now, moving to thyroid nodules, also we should focus on echogenicity. composition, vascularity, margins, shape, and echogenic foci. Those highlighted signs, markedly hypoechoic, irregular margins, extrathyroidal extension, taller than wide shape, punctuate calcifications are very important because they harbor a high risk of malignancy. One type of benign nodules beside the cystic nodules is spongiform nodules, which are highly correlated with benign cytology, and they are predominantly more than 50% of small cystic spaces. We should be familiar with the features of calcifications. They are bright echoes seen within the thyroid nodule or around it. It may be classified according to shape. They are stippled, fine or coarse non-linear particles, curvilinear smooth margins, curvilinear also irregular margins, or it may be categorized according to extent. Linear classifications, arc or linear classifications. Also, rim calcifications involve the entire lesion border, as known eggshell calcifications, which is in most cases are a sign of benignity. The calcifications may worsen the visualization of the nodule content. This is an example of linear calcifications within the thyroid lobe, and this is the eggshell calcification. And the importance of it, when the thyroid tissue extrusive from it toward outside the nodule, and this is a sign for malignancy. This is the most important calcifications, the microcalcifications. It is highly correlated with malignancy. The risk assessment, ultrasonographic science, we have highest specificities for more than 90% of these characteristics. Microcalcifications and irregular margins, as seen in this nodule, and taller than wide shape. We see the diameter of the nodule is just parallel to the trachea, and the small extrusive soft tissue component. And the evidence of extrathyroidal extension also is important. Less specificity is seen with pathologic adenopathy and markedly hypoechogenicity. Also, we should be familiar with the lymph node characteristics, because we need it very important for the staging for thyroid cancer. We see here that this is the sixth compartment of the neck, and this is the seventh. They are the central compartments, and third, fourth, fifth, they are the lateral compartments in the neck. The benign lymph nodules are elliptical. Short to long axis is less than 0.5 centimeters, and the margins are unsharp. The architecture of the lymph nodule is hypoechoic, the echogenic hilum, and without any calcifications. The vascularity are seen within the hilar. This is example for the lymph nodes, benign lymph nodes. While the malignant lymph nodes are seen enlarged, the loss of fatty hilum has a sensitivity of about 1% of cases. The cystic changes and the calcifications has a high specificity, about 1% of cases, but less sensitivity. No single sonographic feature is adequately to differentiate benign from malignant lymph nodules, and in some cases we need to do thyroglobulin washout from the lymph nodules. The American Thyroid Association categorized the characteristics into 5 categories: benign, very low suspicion, intermediate suspicion, and high suspicion. And every one of it harbors a risk malignancy ranging from less than 1% in the cystic nodules toward the 70 to 90% in the high suspicious, when we see it with solid hypoechoic nodules with one or more of the characteristics we mentioned in the previous slides. In general, every hypoechoic nodule need to be FNA'd if it is more than 1 centimeter. Another categorization is the American College of Radiology ThyroAlex, which gives for every characteristic a point. By collecting the points, we see this number of points, and ThyroAlex 1, ThyroAlex 2, 3, 4, and 5, ranging from benign to malignant, and with recommendation when to do FNA with any of them. Now, moving to ancillary imaging techniques, we see that ultrasound elastography, which is measuring the stiffness of the thyroid nodule, it should not be substituted for the grayscale ultrasonography, and it should be done for the indeterminate cytology after FNA, and we may perform FNA when increased stiffness. Also, if the patients are obese or multinodular goiters and coalescent nodules, those patients are not candidates for elastography. The elastography is measuring the stiffness of the thyroid nodule or elasticity, ranging from score 1 to score 4 as in this criteria. Whenever it is more solid, that means it has a high risk for malignancy. This technique was believed to have a very important role in fine needle aspiration of the thyroid nodules, but the variability between the operators and the variability between machines make it need more validation in the coming years. Another important techniques are the MRI and CT scan. They are not recommended for routine assessment for thyroid nodules. We consider it for assessment for size nodules are not seen within the linear array. Also to see the airway compression also in the substernal extension of nodular goiter to assess it, and when the presence of pathologic lymph nodes are not seen within the ultrasonography. This is example for metastatic lymph node from thyroid carcinoma. And also we see here that the scan, CT scan is needed to assess the extent for this huge multinodular goiter, and also its relation to the airway and its relation to the sternum. It's important to avoid iodine contrast when the patient is believed to have thyroid cancer and he needs radioiodine therapy later, because it postpones this procedure. Backing to your survey, thyroid CT is highly indicated in this case, substernal goiter, multinodular goiter, PTC with METs or MTC with METs, thyroid metastasis also, renal thyroiditis, perioperative assessment is, and sometimes we need it. Now, moving to radionuclide scanning, it is a functional imaging to assess the thyrotoxicosis and differential diagnosis, also functional status of thyroid nodule, if it is toxic or not, the thyroid cancer whole body scan for distant metastasis, and also for the estimation of local residual thyroid post-thyroidectomy, and follow-up for tumor recurrence later. In some cases with congenital hypothyroidism, when the thyroid are not seen with by using the ultrasonography to catch the ectopic thyroid tissue, we may need to do a scan. The used radionuclide agents are technetium 99, iodine 123, and rarely we need 131. The technetium is less expensive, more readily available, more rapid examination. After infuse the technetium by 30 minutes we could do it, but it's trapped but not organified, so high risk positive imaging is seen, and also the activity of the esophagus vascular structures can be misleading when the image quality is poor when uptake is low, but by using iodine 123, a better visualization of retrosternal thyroid tissue is seen, better image, but also the cost is high and less comfortable for the patient because we need to wait 24 hours and it is less readily available. Rarely we use the 131 iodine. It's not recommended for routine diagnostic use because it's high cost and high radiation exposure. We use it only to image for thyroid after radioiodine therapy by 3 to 5 days. Scintigraphy either for thyroid scan, and when it's normal we see the thyroid gland as we see here, it is as butterfly, and when it is low, either localized for cold nodules or blank uptake, where the uptake is less than 5% when subacute thyroiditis, amiodarone ingestion, exogenous ingestion of iodine or thyroxine. And when the uptake is high, it also may be diffused as in Graves' disease or localized as in toxic adenoma. The whole body scan, we should differentiate between the normal uptake or physiologic uptake, which is seen in the intestine and also in the bladder and also in the salivary glands, from the pathologic uptake. As we see here, this is the thyroid remnants after surgery, and this lymph nodule. And also we see metastasis, as we see here in this patients with follicular thyroid carcinoma. This meets in the bony tissues and in the lungs. Thyroid scan is highly indicated by Graves' disease, subacute thyroiditis, amiodarone-induced thyroiditis, congenital hypothyroidism in some cases, toxic adenoma, and some cases of Hashimoto's. We should keep in mind that antithyroid drugs should be withdrawn 72 hours before scanning, and thyroxine and iodine and radioiodine infusion, as in CT scan, should be done after should be withdrawn 6 weeks before the imaging, and pregnant or breastfeeding women are not advised to do this imaging, radioiodine imaging. The positron emission tomography, we could see either focal FDG scan uptake and within a thyroid nodule known by ultrasonography that increases the risk, and this nodule should be biopsied if it is more than 1 centimeter, or diffused uptake, as we see in the autoimmune thyroiditis, and this is a benign sign, doesn't require further treatment. This is also may be helpful when in determinant cytology to give us the choice to go to surgery, but it is not used as a routine diagnostic tool. We should know that recently the positron emission tomography is give us a very important rule when the patient has a detectable thyroglobulin or high thyroglobulin antibodies with negative iodine 130 whole body scan. As in this patient, this is a whole body scan with iodine is normal, negative, but this patient with follicular thyroid carcinoma and has high thyroglobulin, the FDG shows us this metastasis within the lungs. So the ultrasonography is the gold standard of imaging of thyroidal lesions, especially nodules. It cannot differentiate always between Graves and Hashimoto thyroiditis. We should be using sometimes the assessment imaging techniques as CT, MRI, BIT to assess the spread of bulky disease, metastasis, adjacent structures, but not routinely recommended as a first line. The radionuclide imaging is a functional imaging to differentiate between thyrotoxicosis diseases and follow-up of thyroid cancer and staging. Thank you very much for listening.